Now, ladies and gentlemen, I think when we consider organ damage due to iron overload, we rarely consider that the bone marrow may also suffer from iron overload. It may be that transfusion dependent causing iron overload may actually aggravate bone marrow failure, thereby causing a vicious cycle again. And we may be able to interrupt this vicious cycle by using iron chelation therapy. And recently there have been an increasing number of case reports and small patient series confirming that there are patients which can be successfully treated with an iron chelator and respond with improved hematopoiesis. And in this table and in the next table, these publications are summarized. And there are erythroid responses, there can even be transfusion independence, and there were also platelet and neutrophil responses observed. And the largest series is the post hoc analysis of hematological responses in MDS patients treated with deferrasirox in the large EPIC trial. And as you can see here, we achieved a 20% response rate, an erythroid response rate of 20%. And half of the patients achieved an increase in hemoglobin by at least 1.5 gram per deciliter, and the other half of the patients achieved a transfusion response, which means that their transfusion requirements decreased by at least 4 units of blood over 8 weeks. And there were also platelet responses and neutrophil responses. And it took about 3.5 months to achieve an erythroid response and somewhat longer to achieve a platelet or a neutrophil response. And the responders tended to have a better decrease in serum ferritin from baseline than the non-responders, but this difference did not reach statistical significance. As you can see on this slide, when you look at the time course of serum ferritin levels, there wasn't much difference in the erythroid analysis group, in the neutrophil analysis group, but there was a substantial difference in the platelet analysis group. And these results seemed, well, surprisingly good, maybe even extraordinary, but they have recently been confirmed in the US 03 trial. Alan List has just published the results in the JCO. And in the US 03 trial, there was a 15% erythroid response rate, a 22% platelet response rate, and a 15% neutrophil response rate. And there were also multilineage responses seen. I will just briefly mention this Italian study, which caused quite some astonishment at the last ASH meeting, because when Dr. Cilloni presented those results, everybody was quite astonished to see a staggering 44.6% response rate. And most colleagues think that this is just too good to be true. Maybe there was some problems with the case ascertainment as far as blood transfusions outside of the medical center is concerned. But I would like to remind you that very similar results have been obtained more than 15 years ago. In Denmark, there was a study published by Jensen and colleagues who followed 11 MDS patients very closely for up to 5 years. And these patients were treated with deferoxamine. And they were treated continuously. And compliance was practically 100%. And this treatment achieved a reduction, a more than 50% reduction in transfusion requirement in 64% of the patients, and 5 patients even became transfusion independent. So it doesn't seem to be absolutely important which iron chelator you use. It seems to be more important that patients really adhere to this treatment for a long period of time. Then you have a considerable chance of success of getting a hematological response. I speculated that this hematological response might be correlated with successful suppression of LPI levels. And therefore, we looked at LPI levels in the EPIC trial. But to my disappointment, there was no correlation whatsoever. Responders and non-responders had practically the same LPI levels, not only at baseline, but also during the whole period of the study. And this was not only true for the erythroid analysis group, it was the same in the platelet analysis group and the neutrophil analysis group. So how should we explain that? Well, probably LPI assessment is just too sensitive. Maybe this is not a good wording. What I mean is that LPI can be easily suppressed, relatively easily suppressed in all the patients, and all the patients indeed showed suppressed LPI levels, both the hematological responders and the non-responders. Because it is relatively easy to suppress LPI, LPI is not a good discriminator to predict which patients will respond or not. Maybe other parameters like cellular labile iron may be able to differentiate between responders and non-responders. So LPI may still be useful for clinical monitoring, and we are now just trying to establish this parameter in Germany. There's the first commercial lab now in Germany which provides LPI assessment. And the advantages are that it can actually detect toxic iron species in the serum. And you can document detoxification if you can suppress LPI. And this gives you much more rapid feedback than serum ferritin, because it takes quite a while until serum ferritin levels go down. And if the LPI levels do not decrease properly, this is evidence of insufficient iron chelation. And this may be due to inadequate dosing or to suboptimal patient adherence. But even if this becomes an important parameter in the future, I think serum ferritin will also remain a useful parameter, because serum ferritin levels are supporting our initial treatment decision to start iron chelation therapy. And serum ferritin levels are also needed to provide evidence of a negative iron balance. If we suppress LPI levels, this doesn't tell us anything about the iron balance. But in the long term, in the long run, we do not just want to suppress LPI levels, we want to achieve a negative iron balance. And therefore, we need serum ferritin. We need serum ferritin levels to come down to be sure that there's a negative iron balance. Now, this is a table which I will not explain in detail. This is just to show that there are many guidelines for iron chelation therapy in MDS. And I think they are all pretty similar. And they all have in common that they concentrate on patients with lower risk MDS who are transfusion dependent and have a certain transfusion history and have a certain prognosis. Prognosis of lower risk MDS patients is relatively good. So these patients can be expected to be transfused for a long time. And therefore, such patients are prone to develop clinical complications of iron overload. So there is this is a common opinion that there's agreement that these are the main candidates for iron chelation therapy. But in the future, higher risk MDS patients may also become candidates for iron chelation therapy. And the idea behind that is that iron overload may cause a degree of oxidative stress that is sufficient to aggravate genomic instability of the pre-leukemic clone, thereby promoting the clonal evolution towards acute leukemia.